Hello, everyone. Welcome to this webinar, India's COVID Crisis and Equity and Justice View. My name is Shali Prasad. I'm the Executive Director of the Center for Global Health and Social Responsibility. Our center is co-hosting this webinar with ICGC, the Interdisciplinary Center for the Study of Global Change here at the University of Minnesota. My particular thanks to Dr. Karen Brown from ICGC, who initiated and helped shape this event. Please note that today's webinar is being recorded and will be available on our website tomorrow. Today, I'm not going to get started with the origin story of COVID-19 and the effect it has had around the world. Everyone watching and listening to this webinar has been affected by it. And yet, the situation in India has shaken many of us. This, the second wave of COVID-19 in India, has been dire and apocalyptic in its imagery. Officially, 300,000 to 400,000 new cases and about 4,000 deaths a day are being reported. Many feel that the actual numbers are much more, perhaps by orders of magnitude. And while we know that COVID-19 can affect anyone, rich, poor, urban, rural, folks from different walks of life, we know that every disaster or health emergency affects poor and marginalized communities more. In today's webinar, we will talk about the story of the COVID situation in India from that lens. To say that the situation in India has affected me personally and professionally is putting it mildly. All our panelists also have deep personal and professional connections in India. And with that, it's my pleasure to introduce today's panelists. Dr. Sridhar Venkatapuram is an associate professor in global health and philosophy at King's College London and is based at the King's Global Health Institute. He's an academic practitioner in the area of global health ethics and justice. He has been in the forefront of global health for over 25 years, starting as a researcher at Human Rights Watch, documenting HIV/AIDS-related abuses in India in 1994. His training is quite broad, with international relations from Brown, history from SOAS, global public health from Harvard, sociology and political philosophy from Cambridge. Before joining King's, he was a Wellcome Trust Research Fellow in Ethics at the London School of Hygiene and Tropical Medicine, and an affiliated lecturer at Cambridge University. During 2018 and 2019, he was a Wellcome Trust Senior Research Fellow at the World Health Organization and as a Fellow at the Global Health Center at the Graduate Institute in Geneva. He currently serves as a chair of the International Resource Group for Global Health Justice, formed in response to the COVID-19 pandemic. Welcome, Sridhar. Our next panelist is Dr. Purnima Madhivanan. Dr. Madhivanan is an associate professor in health promotion sciences at the Mel and Enid College of Public Health at the University of Arizona, a physician by training from the Government Medical College in India, in Mysore, India. She has a master's in public health and PhD in epidemiology from the University of California, Berkeley. She's the director of the Public Health Research Institute of India and is also a director of the Global Health Equity Scholars Training Program in collaboration with Stanford, Yale, and Universities of California, Berkeley. Dr. Madhivanan's work focuses on addressing the systemic inequities that put India's rural and tribal women at risk for poor health and birth outcomes. To address these issues, her work is focused on the establishment and use of mobile clinics, along with self-help programs in rural and tribal communities. Welcome, Purnima. Dr. Karthik Natarajan is an assistant professor of supply chain and operations at the University of Minnesota's Carlson School of Management. A graduate of the prestigious Birla Institute of Technology and Science, Pilani, India, he received his PhD in operations from the Keenan Flagler Business School at the University of North Carolina at Chapel Hill. At the Carlson School, Dr. Natarajan has received several recognitions for his teaching, including Outstanding Teaching Award and being nominated as a finalist for the Business Week Faculty of the Year Award. Dr. Natarajan's research interests are in the areas of social responsibilities and humanitarian and nonprofit operations, with a specific focus on global public health. He has consulted on supply chain issues with many organizations, including UNICEF, USAID, and others in humanitarian operations. Welcome, Karthik. My quick announcement to the audience: if you have any questions for our panelists, please put them in the Q&A section, and I will moderate that section. To get us started, Dr. Venkatapuram, can you give us your current thoughts on the situation in India?
It's an extremely huge question. So I will give you a very general question, which is that we are seeing an escalating number of cases and deaths, and I don't see that slowing down anytime in the next few days or weeks. I think that we have an exponential rise in the number of cases, but also deaths, but we also are not seeing very much information coming out from rural areas. So a significant part of India is peri-urban, suburban cities, and then we also have lots of rural areas as well. So I think that's one thing to watch out for in the next days and weeks, is to see what the mortality is. And the reports that I'm seeing are that there's already deaths in rural areas on a significant level, and lack of any medical care. And so there's already medical care lack of in the rural areas. And so this is actually making the situation worse. In terms of hospitals, I think the hospitals are completely overwhelmed, as you probably have seen from a variety of news reports. I don't see that getting better. And we know that the basic medical supplies are also sort of getting sort of overrun. There's a significant problem, I think, and I'm going to leave it to other speakers to identify what they think. But one is that there's absolutely a really incoherent approach to medical I don't know what the word is, but treatment or throwing anything that people think might be biologically plausible at this, which is creating a lot of other kinds of issues as well. And I think the social and economic implications are enormous. And this is not going to be something that can be recovered within a month or a year. I think we're talking about the impact of generations on what's going on. And I hope that we'll get into more of it, but I don't have anything hopeful to say today about the situation in India.
Thank you, Dr. Venkatapuram. I think the point about medications being thrown at them is very apt. You hear that quite often, that there's a plethora of things that are being thrown at patients sometimes for more deleterious effects from them. Dr. Madhivanan, what do you think? What are you hearing particularly from rural and underserved areas? Could you unmute, please? Sorry.
Sorry about that. Thank you, Dr. Prasad, for that question. Much of my work has been focused in rural and in hard-to-reach communities. And when I'm talking to my colleagues and when we're trying to reach, there's literally a complete breakdown in terms of resources, access, and communication in these communities. Because all of the attention is being focused on the big cities or maybe tier 2 cities right now, and we're not really thinking proactively. Instead of trying to kind of put the fire out in the edges, we are trying to pour all the water in the center of the fire, which we know we can't do anything about. We are seeing deaths already, not just deaths associated with COVID, but also all the other comorbidities, which are a huge issue: diabetes, hypertension, untreated, people dying of strokes. And a lot of these deaths are not being reported because in our villages, we really don't have the system to go and get a death certificate. We just, when somebody dies, we go and bury them in our fields, in our family properties. So you never get to hear about a lot of these issues. So we have major underestimation of the magnitude of the morbidity and mortality that we are seeing, not just associated with it, but also all the other conditions around, which was already a problem in India. And when we come to talk about the indigenous populations, there is literally no word. You go look up media, you look up literature, you look up anything. Nobody is talking about the indigenous populations. And we have about 100 million different tribes and communities in India, but there is not a word. There's not a word about the disabled population. How are we managing them? How are we caring for them? So I second what Dr. Venkatapuram said. This is such a major crisis right now that I don't even know if we have a way to stop the destruction that's happening right now. But I'm hoping we will be at least a little proactive and start thinking, not just 2 weeks or 2 months, but maybe think down the line what we should be doing and preparing for it right now. I'll stop there.
Thank you, Dr. Madhivanan. And now to get a slightly different take on this, Dr. Natarajan, from a supply chain issue, we hear about a lot of trigger responses to shortages and things like that. This must be a nightmare from a logistics viewpoint. What is your take on that?
Right. Thanks for that question, Dr. Prasad. And just as a starting point, I do want to connect a little back to what Dr. Madhivanan said and what Dr. Venkatapuram said. I think the word that comes to me and that I'm hearing from people who I know and who I talk to every day is chaos, absolute chaos on the ground, right? And this is, this is happening in different forms. This is happening from a supply chain standpoint. This is happening from a health system standpoint. And this is also happening from an access standpoint in terms of like how people actually seek care and get access to these health facilities, right? So that has been sort of the operational word that I've been hearing over and over is the chaos on the ground. And in terms of like, what does the situation look like? I want to think about this in terms of both the short term as well as the long term, right? So what do we do the next month, 2 months, 3 months? How do we deal with the situation? But then also there are several long-term things that we have to think about, right? There could be a third wave depending on how the vaccinations go. So how do we make sure that we are actually ready for that? And also how do we make sure that we don't hit the peaks that we are hitting right now, right? So the one thing that really worries me about is the lack of what I call as systems thinking. The lack of thinking about how the different pieces are interconnected. So how the rural and urban pieces are interconnected, how the primary, tertiary, secondary hospitals are interconnected, what happens to other diseases, right? So there are, I think, there are several missing pieces in this analysis. And also, I think another problem that is also happening is there is absolutely no coordination on the ground in terms of both the demand side as well as the supply side. What's happening to all the aid that is flowing in? How is it being coordinated? Where is it being sent to? I think there's a lot of questions around that. And then on the demand side, how are we consolidating information? How are we getting that to people who need that information? And how are we thinking from a systems perspective in terms of matching that supply with the demand? And then those are all short-term issues, right? And then in the long run, we still don't have a strategy about vaccination. How are we going to ramp up capacity? How do we get the 100 crores, 200 crore vaccinations that we still need? There is no strategy around that. Capacity building is going to take time. So I think there is a lot of questions to be answered, both in the short run as well as in the long run. And I'll get into some of these issues as we go along.
Thank you, Dr. Natarajan. Dr. Venkatapuram, you've had the experience of seeing other epidemics and pandemics being unleashed around the world. And there is a general understanding that in India, it's compounded that much more because of the population and things like that. Are you seeing any parallels from your experience in the past to what's going on right now?
That's great. So thanks very much. So the number one thing that I would like to say in regard to, what does this mean in terms of other epidemics or historically, is that it's very hard for people to understand that pandemics are not accidental, nor are they natural events. They're actually very much reflective of social choices and neglect of societies and of the global system. So what we're seeing, not only in India, we've had, huge, in the 1990s, we had the AIDS sort of epidemic, and it's still going on. And the reason why it was spreading the way it was because of the way that the society was structured and the institutions were structured and whether they responded or not. And what we see today in terms of the spread of the coronavirus is also because of the different kinds of choices that India has made regarding its investments into public health infrastructure, which is very distinct from investments in healthcare, and what sort of systems and sort of procedures and political will there is around all those kinds of things. So I would say that yes, there is a significant parallel, and it's a long-standing understanding that pandemics, epidemics, and health inequalities are reflective of social policies and neglect. This is not a random event. This is not a God-made event. This is an event that we've created in our societies and across the world. So that would be the number one sort of lesson. The number two thing is that I think one thing that I've noticed and is that if you think back to the last year and a half in other countries, you will see that it always was the impression that everybody in this country was randomly being affected and everybody was a threat, et cetera. But when you actually looked at people who were dying, you suddenly start to see patterns, right? So it's actually minorities that were dying in the United States more, or in the UK. It was older people, by far older people were dying. But for some reason, if you look at the reporting, even within India by Indian journalists, you see this randomness as if it was randomly being sort of affected. It's not. That is one of the things I think that is for me, I think one of the curious things, but also I think quite an irresponsible thing, is to somehow perpetuate this notion that every Indian is randomly vulnerable to this dangerous virus that's spreading around. It's not. It's actually vulnerability is determined by who you are, what your environment is, what's your background, and all this kinds of stuff. And therefore, we need to look much closer at the kinds of distribution patterns of cases and deaths. And this is something that we should, it just happened a year ago in other countries, and yet no one's sort of asking those questions in India about, well, who's actually dying, who's actually getting it, what are the interventions that we should use in order to be able to do that. And the third thing is that I think by far, people obsess about that one magic solution to this entire problem, which is that, in the AIDS epidemic, it was if we only just got that vaccine, we would stop the AIDS epidemic, or if we just got that one pill, we would stop it. And this is what's happening now, is that we're now obsessing and becoming quite sort of thinking that everything will be fine as long as we get that injection, as long as we get that vaccine. So you become very obsessed by the commodity solution to this entire problem. So if I were to say three things that remind me of other epidemics, one is this lack of understanding that epidemics, outbreaks, health inequalities are socially created and they reflect social conditions. Two is that these are not all randomly, they affect certain people more than others, and we need to find out more information. And three is the obsession with this commodity solution to a really profound social problem, and that requires much more than that one sort of silver bullet to solve it. So I would say that those are the three things that seem to be a continuation, not only from last year, but from previous pandemics and epidemics. Thank you.
Thank you for that. I think it's quite evident in many parts of the world that good leadership, particularly political choices, significantly affect the course of the pandemic too. I'm going to jump to a question from the audience because I think this is apt for you, Dr. Madhivanan. Kelly Gage has asked this question: COVID goes beyond a health crisis. Trafficking and sexual exploitations are also rapidly on the rise due to loss of income, etc. Have you seen that being reported in India, and what sort of effects are you thinking this would have for the long term?
Thank you so much for that question. You're right on when it comes to the human trafficking situation. We already had a huge issue, and just in connection with human trafficking and sex work, one of the prominent advocates who was fighting for social equality of sex workers in Calcutta just passed away, by the name Dr. Jana, because of COVID. We lost a huge giant in the field. We are noticing that there are issues with human trafficking. There are issues with partner violence, very high rates of partner violence, because now people are in lockdown And the liquor stores are open from 6 in the morning to 10 in the morning. And you will not believe the lines that we see in our communities back in India. When the liquor shops open, there are mile-long lines for people to come and buy their liquor and take it home. So there are all these things that are coming together. There are people being put in lockdown. People are not allowed to go out and speak to anybody. So people are in very close proximity. So the risk for intimate partner violence, risk for domestic violence. We are talking to rickshaw drivers. Rickshaws are like taxis for us. They're like these small tuk-tuks. My organization works very closely with these auto drivers because they are our key eyes and ears in the community to help us figure out where human trafficking is happening. And a lot of times what happens is people come from rural communities in search of work. And it's essentially the auto drivers who can sometimes act as the middlemen, facilitating things. So we are trying to work with the auto rickshaw drivers to help us in identifying where a person is in trouble and how we can kind of intervene. But that's a great question. But we do not see the data coming out on any of this, just like what we were hearing. Everything is so much in a crisis on the ground that we can't hear anybody's voice right now because nobody's is amplified. Everything is amplified, nobody is amplified. So it's a mess.
Thank you for that. Dr. Natarajan, I'm going to come to you to elaborate on a point you brought up earlier. We are hearing about some amount of coordination occurring in, say, for example, Mumbai or in Kerala. What are your thoughts on that? And is it a random, sporadic micro event, or is it connected to a larger picture?
Right, that's a great question. Thanks for that. So yes, so I think what is happening in Mumbai, what is happening in Kerala is a step forward in the right direction, and it is getting recognized, and it is getting applause, from across the spectrum, including the Prime Minister and many other people. So some of that coordination is starting to happen. We're also seeing some activity happening in Chennai, for example, as they are preparing for the peak that is still to come. But I think the coordination that needs to happen, I think, is much, much larger than what is happening in Mumbai or what is happening in Kerala, or to some extent what is happening in Chennai right now. So the coordination that is happening right now is more at the health system level, in terms of connecting people who need to access care with the providers that are providing care, right? Whether it is the hospitals or the oxygen plants and things like that. So that is definitely a part of the system, but I think we need much more broader coordination than that. So for example, we are still very much uncoordinated on the supply side. We are still dealing with private channels. We are still dealing with state government channels. We are still dealing with central government channels. And then there is a whole host of donations that are flowing in, right? So that part of the supply chain or the system is completely uncoordinated at this point. And it seems that nobody is taking responsibility at this moment. It is not clear whether it is the central government that is coordinating or whether it is the individual state governments that are doing the coordination. And also it is not clear when the handoff is happening. So what is being collected by the central government, when is it being handed off to the state government? And then from there, how does it flow to individual districts, individual cities? None of that has been figured out yet. So the only coordination that is happening right now is coming in essentially from, hospital beds, oxygen tanks, and those kinds of things. But that is only a very small part of the entire problem.
Dr. Madhivanan, you wanted to add something to that?
Yeah, I just wanted to add to what Karthik said. I want to give you a ground example of the kind of things Karthik was talking about. So I'm working in Mysore district. So the district health officer was in tears when a patient called him and he said his wife is dying of COVID, he needs a bed. And the district health officer started yelling at him and saying, don't ask me, go and ask the district commissioner, because I have no control over any hospital beds. Because my wife is dying of COVID, I can't find a bed for her. That kind of tells you a district health officer is equivalent to a county director, health officer, he has no control over the beds. He has no control over what is happening in his own district, even in terms of the medical systems. And he's saying, you have to go ask somebody else, and that somebody else, it's impossible to reach. So that's just a simple example.
Karthik?
Yes, that is a great example. And I think what is complicating the situation right now is, I think, India and Indians generally have a tendency for jugaad, coming up with solutions on the fly, right? And I think that is coming back to hurt us at this point. What we need is more of a systematic, centralized approach where you know how things are flowing from a system standpoint. This is how it enters the country. This is how it gets to the different states. This is how it gets to individual cities. But unfortunately, this jugaad approach, everybody coming up with their own tweaks in this process, I think that is coming back to hurt us at this point.
It brings up a question about governance overall. And I wonder if you folks can comment a little bit about the governance. There's a question there about the political climate, but I want to bring it beyond a political climate, but from a governance structure. What's gone wrong? Not just for this, like Sridhar, you were mentioning, it's decades of choices that has led to this. How do you see that? Where are we with governance, both in the health sector or otherwise? Sridhar, please.
So I just want to sort of say two things. One is that the governance, governance structure, as you rightly point out, is a very key feature of this. But this is not just for India. This is an issue that has been coming forward in the United States, in Canada, and in other federally structured countries where you have a central and state government and significant autonomy by sort of more state entities. I think that we need to not sort of make this into an exotic India problem. I think this is very much a health governance problem. That is one of the things that we've learned from this pandemic, is that in a crisis, we really see what the health governance structure is within countries and whether it works or whether it does not work. And you will see that, for example, Canada has had one of the worst problems in trying to coordinate its national response because the sort of provinces have their own ideas. And in the United States as well, as you saw, all of last year, is that there was a significant conflict and disorganization and actually, lots of fights between state levels with each other, but also with central government. This is exactly what's happening in India right now, is that on the one hand, we have to remember that in India, health is supposed to be what's called a state level issue, right? So states have supposed to be running their own health program. They have some funding from the central government, and that's always negotiated, but also there's a lot of autonomy, and a lot of autonomy is supposed to have gone to all the way down to the local village panchayat level as well. But in this crisis, what we see is that system not working very well, because what we need is resources, we need information, we need commodities, we need lots of other things to go through those channels, and it isn't. And one of the reasons that I would say that it isn't is because it's a political overlay of that governance structure, right? So when the central government is actually fighting politically with various state level governments, then you're not going to cooperate on the health one. So just like we saw in the United States, where information and commodities were being traded and were being sort of given to some people or not given to other people based on various kinds of allegiances, that's potentially what's happening here as well. So I would say that one of the things that is very clear is that the lack of a health infrastructure across India that is politically neutral and separate from the political governance structure. And what we see is now sort of the consequences of essentially both the health and the political coming in together. And so that's why states are on their own. And even in states, basically families are on their own, right? So they can't actually go and stuff. So what we have is that. And so even, so the two things I'm going to end with is we need to pay a lot of attention, and we haven't done this very much, is that there is a great amount of I don't know what the word is. It's not corruption, but actually taking advantage of people in their most vulnerable states. So that's one thing that's going on, is that essentially this is like a period of famines where somebody who's holding the food is essentially asking whatever they want in order to sell whatever it is. Now we have sort of people dying and people being charged for beds, for oxygen, for any random medicine, whatever the price is. And then second, we do have a significant amount of corruption that's going on. No one's really going to talk about it because it's sort of seen as not important right now, but the level of corruption is enormous. And what we're seeing with all these, as rightly people well-meaning intention, sending money, sending, sort of commodities, is that there's somebody who's going to be gatekeepers for all of these commodities, and they're going to end up sort of having to think about it. So we need to watch that as well. So I would say that, those are all really kind of implicated issues, and don't assume that this is, in India. This was happening in Canada, this was happening in the United States, this is happening everywhere. It just shows you that when people are incredibly vulnerable, there's all these other bad things that come out, and there isn't anyone that's sort of really there to kind of balance that or identify that in this kind of crisis situation. Thank you.
Thank you for that. I think that's very important to keep in mind, how health governance in itself is a separate issue than your regular structures, and how it can work for some, but not for health emergencies. Dr. Madhivanan?
Yeah, I just wanted to add to what Sridhar was saying. The coronavirus has exposed a fundamental flaw in the planning horizon for Indian government and for its public health system. But this isn't unique to India. This was the same problem that turned the pandemic that could have been mitigated and managed in the United States early on last year, that turned into a disaster that killed over 600,000 people. Mm-hmm. So this health policy decision-making has literally been compressed to the length of a typical news cycle, be it here or be it in India. The government of India, state governments, health authorities, down to the level at a district, are so driven by the short-term perspective that they have become utterly incapable of maintaining a sustained public health effort for more than a couple of weeks. Every time they institute a new policy, they're already recalibrating their policy within decisions being made within days, because the public is disenchanted with the present policy. Inevitably, this leads to this kind of series of extreme short-term policy decisions that swing back and forth like a pendulum, followed by the public horror at how people and how poor governments are handling this pandemic response. So the research is clear on this. These short reactive policies, be it curfews, be it lockdowns, or decisions to allow for unfettered mass events, damage faith in the government. They feed skepticism into the disease control methods, and they feed growth in this pandemic. And there's already evidence that only policies based on about a 3-month horizon for suppression measures are effective in managing the reproduction number. Unfortunately, this is not within the decision horizon of our current policy and decision-making models. And that is something to think about as well.
Yeah, it's the whole premise of you can't really govern by social media, right? So, Karthik?
Yeah, so again, really important and interesting points that both Sridhar and Purnima brought up. I want to add a couple of points. One point right away to what Purnima was saying, which is, even today, if you look at the news, they are already thinking about changing the second vaccination window. So it went up from 4 weeks, it went up to 6 weeks. Now they're talking about 12 weeks, right?
Yeah.
So when you change guidelines like this on a weekly, daily basis, I think people lose faith in the vaccination itself, because I have seen a lot of questions from people who are well informed. They're asking, so how do I trust these guidelines? What changed from 3 weeks ago to now say that we will go for a 12-week window rather than 8 weeks? And then it was 4 weeks, a few weeks before that, right? So that is hurting us for sure. And then going back to what Sridhar said in terms of the governance, I think there are 5 clear factors from a governance standpoint that I think led to this crisis, and that is really important to think about in terms of the future wave as well. So the first was the complacency, right? And in some sense, the first wave actually was a disadvantage for India because the wave was actually managed pretty well, at least in terms of not as worse as the second wave. So I think that led to a lot of complacency, both within the government and the society. And also the cases were declining from November all the way to January, right? So complacency was the first piece. And I would say that is a failure in terms of the governance. The second piece is total failure in terms of anticipating the second wave, right? There were signals in February from Mumbai and other places that should have set alarm bells ringing within the government. That didn't happen. And then the other point is you have to look at the experience of other countries. Pretty much every single country had a second wave. And India was under the impression that somehow the second wave will not happen. So that is another problem in my mind. The third is, this is where I think governance really was a failure, which is missed opportunity to build capacity between November and February, right? So 4 months, we had a relatively lull time where we could have done a whole host of things, whether it is in terms of vaccinations, whether it is in terms of building oxygen capacity, hospital capacity, and things like that. In fact, what we ended up doing was we actually went back and dismantled many of the systems that we had put in place. So that is another failure of governance in my mind. The fourth, I would say, is complete miscalculation in terms of how much vaccines were needed and when we would place orders for those vaccines. So if you look at the US, right? So US was placing orders back in May and June of 2020. India has a high manufacturing capacity, and India did not place orders until January of this year, right? The reason was they thought the second wave was not coming. So they felt like they had enough time to spread out this vaccination over this whole year. And this is where I think we are completely caught blindsided. So that is another problem in my mind. And then the fifth is, of course, elections, rallies, religious gatherings. All of these were done obviously for political purposes. So that is another key factor in this whole structure in my mind.
I like the term complacency you mentioned, Karthi, because I think there's also one other term that I'm seeing from friends and others about the exceptionalism of India. There was a lot of folks who talked about, oh, we didn't suffer much because we are exceptional, we can handle this. And there was almost an arrogance that came through with that, which unfortunately has been quite devastating. There were a bunch of questions about the second wave, and I think, Karthik, you've answered most of the questions about why it's hitting so hard and why we're having so many more people die from it. Here's a question. There's from Fred Rose. India has a mix of public and private healthcare. Are both struggling equally? Are people paying for private healthcare doing better? I know my thoughts on this. Who would like to take this question? Purnima?
It's an interesting dilemma. I think we have come to a stage in the pandemic where initially people who could afford good healthcare could actually access the good healthcare, or they could afford enough money to fly abroad, which is what a lot of the rich people have already done. They've left India. But for those of us, like 60 to 80% of our healthcare costs in India are out of pocket. So even for an average middle-class person who has a job, a white-collar person, if they have one person admitted in the hospital, that is going to have enormous effects down the line. That is the only earning member in the family, we're all screwed. And that is no different right now for public hospitals or private hospitals because everybody is overwhelmed. We do not have enough healthcare resources to even handle people who can afford to pay the money. This is where the reality strikes. Even if you have money, it means nothing when you don't have the resources on the ground to buy. And that's where we are right now.
Yeah, it's important to keep in mind just the sheer volume, right? 1.4 billion people. Sridhar.
Thanks. Could I just ask? Could I just answer this? Is it because I would like to focus more on the ethics and equity stuff rather than the kind of how do we solve this problem from an epidemiological or economics point of view. I think it's an important question, and the way that I would answer it from the equity and ethics point of view is that fundamentally, the government of India does not think that every citizen has a claim for health or health care. This is one of the fundamental things, is that in the last 10 to 20 years, is that the government approach to health has been that we will provide opportunities for people to buy their own health care and healthcare insurance if they want to do so. And this is not only a domestic reason, this is sort of from international. There are lots of powers that be that have been trying to say we should think about healthcare as more of a consumption good, that individuals will sort of pay according to what they think is valuable for them. But the basic underlying idea that somehow every citizen has some sort of claim or right to health or health care is absent in India. And this is one of the reasons that we are in the situation that we are today. The questioner sort of somehow made it seem like there's an equal amount of public versus private in India. That's absolutely not true. In the constitution, because the founders of India thought that every citizen should have access to healthcare, they made a right to access to healthcare. But in reality, that right has never been realized. So only the very, very poor end up going to public hospitals and literally sleeping on the floor in front of the hospital and waiting for their turn to get healthcare, while everybody else has to pay for it or goes and finds a place that they're going to pay for it. They're not assured of quality just because they're paying for it. They're just paying for whatever it is that's available. And so that we are not having a conversation at all about the quality of healthcare that's being provided in majority of the marketplace for healthcare. And as Purnima just said, is that if you are wealthy, you would have gone already to the really wealthy hospitals and you would have gotten your care, but also your vaccinations. Somehow magically vaccinations appeared for the wealthy and everybody's been vaccinated and twice because they already heard that the young people might be vaccinated, so they should go get their second vaccination. And so somehow power and money has managed to usurp any equity and egalitarian underpinnings that might have existed in India already. So that's a long gone situation. So I just want to sort of really kind of bring it back to the kind of equity and ethics founding principles of this. That is wrong, because in the future, if we don't keep the focus on those principles, then people will say, okay, well, what kind of system are we going to build that's most efficient in dealing with this epidemic in the next time? Rather than saying, how can we guarantee every citizen has access to health and healthcare in the future? Thanks.
That's a wonderful point. It brought me memories, Purnima, of our training place at the Mysore Medical College. Karthik, your points, please.
Yeah, so I just wanted to add to what Sridhar said in terms of, the equity piece, I think is coming from the way the system has been designed and the way the system has been funded for a long time, right? It's, I'm thinking even of when you have to go to an ER, it's not like the US where, they decide where to take you. In India, it's about where you want to go, and people with the resources go to the best places. And then if you don't have the resources, then you have to go to a government hospital, right? So there is almost like a implicit tier system depending on how much wealth you have. And the second problem, I think, is especially with COVID, I think the problem has been complicated by the fact that people who didn't even need access to healthcare ended up being in a hospital just because they felt like they should be in a hospital, right? They were not serious enough to be actually admitted, but then they said, I have COVID and I have the money to pay to be in a hospital, so let me actually be in a hospital, right? And this is where I think equity comes into the picture. So if you have the resources, then basically you could do whatever you wanted a month ago, not today because every hospital is full, but a month ago or month and a half ago, if you had the resources, you could basically do whatever you wanted, whether it is in terms of getting oxygen tanks, whether it is hospital beds, ICUs, you could get whatever you want. And then people who didn't have the resources had to go to the government hospitals. And again, resources were not distributed equitably, right? So, and that is another problem, which is medicines and medical supplies are not distributed through the hospitals. They are available in the open market. So again, if you're willing to pay more, you could go and buy those tanks, you could go and buy remdesivir and things like that. Same is happening with vaccinations right now. Vaccinations are not free for all. And in fact, I think within the last 15 days, the prices have gone up almost 6 times. The vaccine used to be 250 rupees in private health clinics. Today it is 1,500, right? So if you think about a family of 4, that is shelling out 6,000 rupees. And not a lot of people can actually afford that. So they're going to wait for government centers to offer those vaccines. And those might not be available for many months because, again, the government is paying a different price. The private entities are paying a different price. So they're likely to get access to that first.
Prima, you want to add?
Yeah, I think Karthik kind of hit it on the point. But one of the things that we have to step back and look at the bigger picture is what Sridhar was talking about, these inequities, is how the healthcare system is being supported and funded. We produce some of the largest number of medical doctors in the world. Most of the hospitals here in the United States will have at least one Indian doctor. But we do not see that same kind of representation in India. But what is really kind of counterfactual here is people from all around the world go to India to get their medical procedures done, medical tourism, one of the big booming industries in India. Now, when we go right down to the public health system at a village level, we don't even have a freaking healthcare system to take care of simple diarrheal diseases where people are dying. And the government has not thought much about it. So we have this wide range, all the way from medical tourism, which means you can get the best care in the world at an affordable cost for an outsider. At the same time, a child cannot get a $2 medication to survive because of a diarrheal disease. Those are the kind of differences that we need to start acknowledging. Where are we putting our interests? Where are we putting our investment? And who are we trying to please? If we have 1.2% of our GDP is the investment in health, and in that about 1% in public health, you can only imagine if you compare it to 18% of the GDP for the United States.
Yep.
That's the difference we're talking about.
I'd like to bring up one other point. Sridhar, you brought up appropriately the issue about ethics, and I think it's a twofold question. One is ethics as deemed by public policy and how we follow up on our ethical frameworks in designing the structures. The other part is about what we do for each other. And it seems like any epidemic can either bring the best of people and sometimes the worst out of people. Could you elaborate a little more on how people's behavior has added on to the challenges we are seeing in the ethical sphere?
Yeah, I mean, I think you're asking such a wonderful question and such a complex question. So very quickly, just as a mini 20-second lecture. So I think that in terms of health and ethics, we've focused very much on this idea of medical ethics and research ethics, and how doctors treat their patients and how researchers treat their subjects. And I think that's really important. And as we see in India, there's a lot of issues right now, just in terms of what the rights and responsibilities of patients are and what good and bad behavior of medical professionals is. I want to put that aside and rightly focus on what you're talking about is much more about social ethics and also more political ethics. But the social ethics, I think, is really important. And one of the things that I always keep saying, and people don't like me saying it, is that Indians love inequality, right? Indians love to differentiate themselves from each other based on some sort of status. And this is funny sometimes, but it's also not funny in terms of the implications that it has on other people. And so what we are seeing, you know, in India, nobody's talking about it, but the fact that is over the last year, despite this pandemic, when people were told to stay at home, and what happened was that some people couldn't stay at home because they don't have a home in which they can live together, comfortable with other people, etc. So we didn't really think about each other in terms of how possible it is for everybody to be able to protect themselves from this dangerous, potentially fatal disease. So that's one way in which we're not even mutually thinking about each other's abilities to protect each other against a crisis. The second thing is that inequality, just even within Indian households, every middle-class person up to above has a household that's profoundly unequal in lots and lots of different ways, whether it's even between intergenerational or between the fact that there's a household and there's staff, people have people that clean, that cook, that all this stuff. And those people were expected to continue to come and work in those households, putting both the people that work and the households in danger. And this is one of the consequences that we are seeing, and no one's really sort of thinking about that. So imagine if you actually use this catastrophe of the pandemic to rethink our relationships with each other away from status inequality and thinking how much better I am than my neighbor and this person that cooks and cleans, but to actually think of all of us as saying, look, we're all being faced by this incredible threat to our lives. How can we transform our relationships so that we can take care of each other, so that we can actually survive this catastrophe where the government isn't going to do anything, where, you know, our temple isn't going to do anything for us, our, you know, who is it going to that's going to come save us now? But actually, if you actually change that relationship and say, how do we take care of each other so that no matter where we are in this society, at least we can protect each other in this sort of local and immediate way? I think that would be a profound, you know, opportunity here. But what I'm seeing is rather the opposite, which is, I'm wealthy, I'm going to get the vaccine first, I'm going to leave the country because I can, or, you know, those people are sick, there's a nurse working in my hospital, I don't want her, you know, I don't want her to live in my building, so I'm going to kick her out because she's going to, you know, so that kind of awful, you know, what can I get away with because of my status, and how can I sort of exclude people and protect me and myself and us and them and all that kind of stuff. So there's a real opportunity here to go either way, and I think there's sort of some people are trying to go towards the better part of ourselves, but I think there's not enough talk at all about how more of a kind of mutually respectful way that we could come out of this and address that sort of long-standing inequality to sort of, you know, sort of at least during a period of, you know, incredible crisis, we could come out of this a little bit more equal, or at least sort of, you know, showing a little bit more respect towards each other, no matter what our differences might be. Thanks.
That's a very important point. Thank you. Thank you for that, Sridhar. One of the question that has come up from our Dean of the School of Public Health is, how will this change public health in India? If you had a crystal ball, how would you like it to be different in the future? Go ahead, Sridhar.
So, so I don't know if people are aware, but, you know, so basically the public health infrastructure is profoundly weak in India, and you will see that, you know, there were essentially not even one epidemiologist per state government at the beginning of this pandemic, and people were suddenly trying to understand what an epidemiologist was and why they need to have one. So there's a difference. This is one of the long-standing problems, is that people conflate medical care with public health. And this is one of the big problems. A few years ago, I think now it was like more than 15 years ago or 20 years ago, a group of people decided that we should set up public health institutions. And so there you have the Public Health Foundation of India that became almost like the premier public health institute. They were sort of building institutes around the state, but then they got into political trouble and they were essentially eviscerated. So now they're just a very small shell of what they used to be. So even the educational training that was going to be provided has been cut back. So I don't don't know what the future of public health education, training institutions are in the future. It certainly is not going to be the same institutions as before, because the people in power did not want those organizations to continue. Unless some other institution takes that up, some other institution figures out a way to educate more public health people. I don't know. There's been a long-standing history, and I think very admirable history, where very local organizations have been doing fantastic public health work in communities in certain states. And there's people that come from the world over trying to learn from how to do public health in that very local, immediate, relevant, community involved way. But I don't know how we scale that up in the future. I don't know how we can do that in a very large scale, given the demand and given the consequences of this. So I would say, just to sort of quickly wrap up, one, there's been a long-standing sort of neglect of public health as distinct from healthcare. Two, the institutions that were built starting in the 1990s, early 2000s were completely eviscerated over the last 5 to 10 years. And three, there are continue to be small, local, community-led public health organizations. I hope that they're surviving, and I'm sure they're also being affected, but how we can get them to continue and scale up is still uncertain. So those are the three things that I would say. Thanks.
Thank you, Sridhar. The conversation about the primacy of clinical care is so prevalent all over, and particularly in India. That's a good point. Purnima, your thoughts on that?
Yeah, I just wanted to take us back all the way in terms of our educational system. We have a lot of doctors, they're very well-trained doctors, but there is, again, a class even in terms of what specialty you choose. Public health is one of those black orphans that nobody wants to touch. That means if you're in medical school, and when you get ready for your residency, the folks who they think land up going into public health are people who are no good at anything, but they still manage to get the basic medical degree. Those are the folks who will land up going into public health. So there's that stigma associated with it, which has not gone away even now. So that's one part of it. The second part of it, when we need doctors in the public health systems, the doctors can only do what is available to them in terms of resources. That means the government has to provide the necessary resources so that doctors are not frustrated and they leave. So this is a two-sided coin. It's training enough people, but also making sure they have the resources to do what they're supposed to be doing on the ground. Unless we kind of address both at the same time, we're going to continue to have these discussions.
Thank you. Sridhar, from your side?
I said mine, so I think Karthik should
Karthik, your side?
Yeah, so I have just 2 points in, on top of what Sridhar and Purnima said. So I want to end on a little more positive note. So I think one, improvement or positive that I see coming out of this is a little more emphasis on data in public care and public health and healthcare settings. It's not complete, but I definitely see a movement towards at least collecting information on the health side. A lot of different states now make some of this information publicly available. So at least that is a movement in the right direction towards a more data-driven decision-making culture. The second, I also see as sort of not as a positive, but coming out of this is states have realized, and the country has realized that the completely decentralized state-driven model may work for day-to-day healthcare, but not in an emergency setting, right? So there has to be a completely different paradigm as to how you deal with emergencies. So in those situations, you cannot rely on just states to handle the situations. There is a role for the center. And I think I hope the positive development will be that states and center comes together and agrees that this is how we will deal with emergencies. This will be the role of the center. This will be the role of the states, and how that power and responsibility will be shared in case of a health crisis. So I hope that is another thing that happens because of this crisis.
Thank you, Karthik. My personal thanks to all of you, Sridhar, Purnima, and Karthik. You've been fantastic in this. The challenges obviously are very personal for all of us, and professionally we feel frustrated We hope that we have better paradigms in the future. And some of the things that we've talked about seem like they're really long-term issues, but I think engaging in those conversations is very important even to mitigate the current crisis. So I appreciate your honesty in this. My personal thanks to Dr. Karen Brown for our co-host in this, and to Anna Pendleton, who did an amazing job to make sure the technology stayed live and good. Thank you, everyone. Bye now.
Thank you very much. Bye-bye. Stay safe.
Thanks, everybody.
Thank you, everyone.